So these are just tiny little septic emboli that cause microinfarctions of the tiny vessels supplying the nail bed. This is a sign of septic emboli being thrown from the vegetations on the cardiac valves. A great sign of bacterial endocarditis. Now, do you think this image is high yield? Of course it is. I can show you this image, and I expect you to know everything about the pathophysiology of bacterial endocarditis. Now, so we're throwing septic emboli from our damaged valve. What are some other consequences of having a damaged valve due to bacteria? The damaged valve can cause a new onset murmur, and the bacteria will activate the immune system, causing a fever. So, a new onset murmur and a fever should make you concerned about bacterial endocarditis. Now, what about the anemia? This answer is available in our hematology section. So, it is an anemia of chronic disease, right? How high yield is that? I've tied in microbiology, and now I'm going to tie in a little bit of hematology. Examiners love endocarditis. This is an excellent opportunity for us to review anemia of chronic disease. So our body has an adaptive response of trying to hide iron anytime our immune system is activated, even if there are no actual organisms present. We do this as an adaptive mechanism because all living cells need iron. Now, this is an excellent opportunity for us to go through the presentation of some lab values and the physiology behind anemia of chronic disease, as particularly seen in the situation of someone that has an underlying bacterial endocarditis. So, let's think about it. We have activated macrophages because we have an immune response, right? And that's eventually what's going to happen. These macrophages are really angry because they either have to fight off an infection or they think that they're trying to in the case of an autoimmune problem. What do macrophages do besides phagocytize things? They release chemokines and cytokines. They release IL-1 and IL-6. Oh my gosh, now we're tying in some immunology. This is crazy. This is what test examiners will do to you. They expect you to know everything and expect you to know it so well that you can put things together in your mind. Now, what does this IL-1 and IL-6 mean to you? I'm about to tell you. This is in your first aid book under non-hemolytic normocytic anemia. So IL-1 leads to the downregulation of erythropoietin receptors on the erythrocyte precursors or erythroblasts. It also decreases the ability of interstitial cells in the peritubular capillaries to decrease EPO production. So we've downregulated EPO receptor and EPO production by the interstitial cells in the peritubular capillaries that make EPO to begin with. That's another high yield fact. So IL-6, what does that do? It tells hepatocytes to start making stuff. What do you think it tells the hepatocyte to make? It tells it to make hepcidin. Hepcidin is an incredibly important molecule. It's basically the reason why people have anemia of chronic disease. If you have high levels of hepcidin, you have high levels of hepcidin activity. What does that even mean? What does hepcidin do? Hepcidin inhibits the production and functionality of ferroportin. So what am I doing if I'm inhibiting ferroportin? So ferroportin is a transmembrane protein that helps transfer iron out of a cell. So let's imagine a cell, and this is ferroportin. It's like a little canal or a port. So if you just look at the name, it helps you to remember and understand this. Ferroportin is like a port in which ships dock to receive cargo. What ship is docking and what is the cargo? So, ferroportin is the port that which our ship, transferrin, will dock and receive its cargo. And normally, transferrin is going to come by and pick up its iron and then go around its merry way and start giving iron to its tissues. If we are downregulating ferroportin, we're not going to be giving transferrin any sort of iron. So there will be decreased transferrin saturation. So that is one element of transferrin that is testable on your test. So hepcidin is high, transferrin saturation is low. So transferrin is circulating around in the blood, trying to get iron from ferroportin, but it can't, because the only way ferroportin can leave from cells is via ferroportin. So for example, the macrophages that are breaking down red blood cells, they cannot give iron to ferroportin, and ferroportin cannot give iron to transferrin. Hepcidin inhibits the interaction between ferroportin and transferrin everywhere. ferroportin is found. That means ferroportin is unable to transfer iron to transferrin. Transferrin is the molecule that is responsible for taking iron to other places in the body. Now, what is the macrophage going to do with the iron? It's accumulating iron intracellularly, right? It usually gives it to ferroportin, and then ferroportin is like, here you go, man, take it, transferrin, take it wherever you want, but we can't. So this high level of iron within the macrophage has to be stored somehow. You can't just have free iron chilling inside your cells. That's how you get damage. That's really bad, right? We don't want accumulation of intracellular iron because we get Fenton reaction, we get reactive oxygen species, we get damage. Now, what's it going to do? It's going to store it as ferritin. So far, we have high hepcidin and a low transferrin saturation because ferroportin is being told by hepcidin not to give any iron to it. So you think high hepcidin will be a part of the question? No, too easy. It's going to show you a very low transferrin saturation, super high levels of ferritin. What else are we going to see? Well, let's think about how we regulate iron to begin with. This is our enterocyte. It has a brush border. So this is the lumen, and then this is the blood side. Remember, we have heme transporters on the luminal side, and we also have a divalent transporter. On this side, we're allowed to take in iron, and here we're allowed to take in heme iron. Either way, this enterocyte is going to bind iron and store it within itself as ferritin. There's the port again, so this is ferroportin, and we need ferroportin to give iron to transferrin. It is circulating around in the blood, transferring iron from itself to other tissues, and that is the role of transferrin. Hepcidin comes in here and says, nope, absolutely not. We are not doing this. So, in enterocytes and in macrophages, we're going to accumulate a bunch of ferritin because that is the only way we can store iron safely within the cell. When this enterocyte sloughs off, it's going to get excreted in our feces. This means that iron accumulates within our enterocytes and just gets eliminated in our feces when the enterocyte sheds off. Alright, excellent. Now, let's focus back on the title of the actual slide, Bacterial endocarditis. How does Staph aureus get access to the heart anyways? Number one answer, IV drug users. So, intravenous infectious disease basically, right? They're sticking themselves with a dirty needle that has Staph aureus on it. And this is the same reason that they get endocarditis from Pseudomonas and Candida, right? These are things that are everywhere. And if you use a dirty needle or you didn't clean your skin, you're just going to introduce it directly into your venous blood. All it takes is one crazy idea like, hey, let me shove that dirty needle into my vein, and you're going to introduce the organism, doing it a huge favor by directly putting it into your bloodstream. What is the first valve that the venous blood is going to see? The tricuspid valve in between the right atrium and the right ventricle. Venous blood is coming in this way. Now, what are some of the complications of endocarditis? Well, we can damage any sort of structure within the heart. Particularly high yield are the chordae tendineae, because this is how we can tie a physical exam finding with some of the damage from bacterial endocarditis. This can lead to rupture, and the chordae are responsible for holding the anterior mitral valve leaflet and the posterior mitral valve leaflet in the situation of mitral valve regurgitation. So we can have new onset regurgitation. Most likely, they're going to involve either the tricuspid or the mitral valve when they give you the clinical presentation because they're the most easy to hear. Now, what are some other things we need to be worried about? Extension of the infection from the myocardium into the pericardium, right? And this is that situation where we're worried about pericarditis again. And it can be suppurative pericarditis, right? Because this is a word that indicates that there's a bacterial infection, there's pus, our immune system decides to ramp up an antibody response, and then we get a pericarditis-like presentation. Another potential complication is glomerulonephritis. Why would that be the case? Well, our body started up an immune system response. We started making antibodies against this bacteria. These antibodies have to get filtered somewhere, and they start depositing in the glomerular basement membrane. So we get a glomerulonephritis because there is inflammation within our glomerulus, and we start getting blood, albumin, and things like that in our urine. Okay guys, great job. Now that we discussed the really dangerous one, let's talk about the subacute one. We talked about acute, and that's mostly due to Staph aureus. Now subacute, what does that mean? So subacute endocarditis is a more indolent, which means slower developing, less intense progression of symptoms because a lower virulent organism causes it. That is viridans streptococci. It does not have all of those wild, crazy virulence factors like Staph aureus. In fact, it's so puny it can't even infect a normal healthy valve like Staph aureus. It needs a previously damaged valve. So your classic thing that you need to worry about in subacute endocarditis is someone that has a history of some sort of rheumatic fever, some sort of mitral valve prolapse problem, calcified valves, a bicuspid aortic valve, which also leads to calcification due to chronic fibrotic damage and dystrophic calcification, or a synthetic surface such as a replaced heart valve. Yeah, makes a lot of sense, right? Because that way it has a very easy medium to grow on. Now, where does viridans streptococci even come from? It's a commensal organism in our oral cavity, in addition to the Hayseck organisms, right? So these are in our mouth. So if you floss really hard or have a dental procedure causing some gingival bleeding, the bacteria can say, hey, check that out. There's a little bit of blood access there. Let's get in there, get into that damaged capillary, get into the venous circulation, and now we can go to the heart. This is why anyone with a prosthetic heart valve used to get prophylactic antibiotics at the dentist. Recent studies have shown that it may not be beneficial. It's controversial. Who knows? That won't be your question. Your question will be which organism is with subacute, which is viridans streptococci, which is with acute, classically Streptococcus aureus. Now, don't forget about your Hayseck organisms that are also commensals in the mouth. Another extremely high yield is Streptococcus bovis. That can be a cause of bacterial endocarditis in a patient with colon cancer. Is this particularly high yield? Yeah. Why? Because I'm tossing in another type of pathology. I'm worried about colon cancer. Wait, they have heart problems? What's going on? If we culture Streptococcus bovis out of a patient's blood with infective endocarditis, what should we be worried about? Well, let's say we send them to our gastroenterology buddy. Those are the best kind of friends to have, and we have an immediate colonoscopy done because we're worried about colon cancer. Wait, why do we just send them to our colonoscopy buddies? Do we just like doing that? Well, did we just accidentally hit the colonoscopy button? No. We knew our stuff, and we thought about Streptococcus bovis. And we said, oh, wait, Strep bovis is a commensal within our large colon. And if someone has a malignant tumor in the colon, then there's going to be ulceration and bleeding. Perfect environment for Streptococcus bovis to access the blood and then travel to the right side of the heart and cause a subacute endocarditis. Now, what about the culture negative bacterial endocarditis? Does that mean that there's no infection? No, it just means that when we culture it, we don't see anything. Why? Well, culture negative endocarditis is usually due to Coxiella burnetii and Bartonella species. They are intracellular organisms. They will not grow in any medium. You have to have them inside of a cell. Will your culture show you a negative result? Yes. Is there actual infection? Yes. So this is an incredibly high yield element for you to know. I can give you the presentation of bacterial endocarditis, and then I'll show you a culture plate, and there's nothing. And now you're like, wait a second, why does this person have everything of an endocarditis presentation, particularly bacterial endocarditis, and I don't see anything on this growth medium? That's because Coxiella burnetii and the Bartonella species need to be intracellular. They need organism invasion of myocytes to live. And that is the culture negative group. Highly testable material. All of this. Endocarditis will show up on your exam because it kills people if you don't recognize it. Now, what about an endocarditis? What if we took out the bacterial? Then it just means that we have endocarditis without the bacterial infectious component. What are some conditions in which we can have an endocarditis that do not include some sort of infection? How about a malignancy, a hypercoagulable state, and lupus, systemic lupus erythematosus? First of all, malignancy and a hypercoagulable state should be grouped together because malignancy is a hypercoagulable state itself. Tumors can produce anything including clotting factors or tissue factor. But a particularly high yield association here is a mucinous cystadenocarcinoma. Why? Just think about how viscous mucus is to begin with. If a tumor is constantly producing mucus, fibrinogen, and platelets, it could easily stick to a valve and cause a clot. So these can cause vegetations with an endocarditis-like presentation without a bacterial component, right? Another particularly high-yield element is that these sterile emboli tend to get stuck on the inferior aspect of a heart valve. So let's say this is your posterior mitral valve leaflet. Here's the left atrium, here's the left ventricle. These guys will get stuck on the underside, as opposed to bacterial emboli, which tend to form on the superior side. That's a great high-yield way to show you a picture, and there's a vegetation on the inferior aspect of a valve, and you automatically know that it has to be a non-bacterial-like process going on. Let's incorporate a more practical image of something you might see on your Step 1 exam. What does this look like to you? This is an echocardiogram in which you can see a vegetation sitting here. It's on both sides of the valve, on this inferior side and on the superior side. Why both sides? Well, we just said that bacterial endocarditis usually has vegetations on the superior side, and a non-infectious endocarditis usually has vegetations on the inferior aspect, not on the superior. So what could have vegetations on both sides? Something weird that is complex, and lupus. That's always the great answer to everything. As many times as that will get you caught being wrong, that's actually the right answer this time. This is systemic lupus erythematosus vegetations. This is called Liebman-Sachs endocarditis. Now, why is it on both sides? Systemic lupus erythematosus is a very unique autoimmune disease in which the underlying problem is that we have a defect in the clearance of cells that undergo apoptosis. Apoptosis is normal. It goes on all the time. But in lupus, there is a problem in the packaging of cell components into apoptotic bodies for appropriate disposal. This means that any type of cell can be abnormally disposed of, and if the immune system gets a hold of it, you can guarantee that it's going to make antibodies against it. This includes antigens present on heart valves. The antigens present on heart valves are all over it, on both sides. I remember this because one of the antibodies that can be found in lupus is anti-cardiolipin. The antibodies stick to both sides of the valve because they are binding against normal antigens that are found on all areas of the valve, which is where the antibodies are directed to anyways. Do not expect the classic buzzword Liebman-Sachs endocarditis because they don't want you to remember buzzwords. They want you to think through the pathophysiology of lupus and that there's normal apoptotic clearance of antigens. Some sort of antigen such as the endothelial cells on both sides of a heart valve can trigger an immune response, and you start depositing antibodies and activating an immune response that causes cell accumulation and vegetations on the atrial and the ventricular side of the heart valves from lupus. And that is why you need to know the pathophysiology of it.